COVID-19 is the disease it causes. It's SARS-CoV-2. It is in the family of the SARS viruses, so it's similar to the SARS that we had years back. It's also called nCoV, or a novel coronavirus. So it goes under different names, but it's all the same thing. It is a viral illness, and it can affect your lungs and airways mainly. Main symptoms are cough, high temperatures, fevers, and shortness of breath. But people may have all of that, or none of that, or may have a sore throat, or diarrhea, tummy upset. All those have been described, but it's basically just feeling icky and flu-like. It's at this point not exactly known how COVID-19 spreads from person to person, but it's clear that it does spread from person to person. And we just extrapolate data from viruses that are in the same family that we know from before, and we do think that it spreads through the droplets in a cough or when people are sneezing. So that, and I'm going to get back to that a little bit later, that's obviously if somebody's coughing at you, or if it's on surfaces, then you can get infected. The first case of that was described in China, in the Wuhan region, in December of 2019. And it's now, as you all know, a worldwide spread and a pandemic. So at this point, this is what the world looks like. These are active cases right now. So China, by no means the front runner anymore, and you can see an awful lot of yellow in the United States, that where the cases are really exploding, and we need to do something about that. So in Washington right now, we have a little over 6,000 cases. Just since yesterday, we have almost 500 new cases and 254 deaths. In the US as a whole, we have well over 200,000 cases. Just since yesterday, there were 27,000 new cases, almost. And then globally, we are now, actually, this is already an old number, we have just hit 1 million cases. Just since yesterday, there were 74,000 new infected people. So this is spreading really, really fast. Some people, or most people, recover, and we're going to see how long that's going to take. It probably, to get immunity, takes a good 28 days, and we have no idea how long the immunity lasts. So if we're looking at how fast this is potentially spinning out of control, here the black line that has the little blip in about February, that's the Wuhan, that's the Chinese region where we initially got all the reports. So once they were escalating up, and if you remember, we really felt like they were escalating up and it was everywhere and they had to build new hospitals, that was where they were. They were just under 10,000 cases at that point. And then they had very, very strict measures where they did very strict social isolation. They got everybody off the streets. Everybody was wearing masks. And you can see over time how now we have no new reported cases, but they still have not really let go of their isolation. So they've really got that under really good control. If by comparison, you look at this line, the salmon line that is spinning out of control, that's the United States. We are not doing a good enough job of social isolation. This is really scary. Our healthcare system is not going to be able to sustain that. This is the United States as a whole. So if you look at on your left-hand side, this is what the United States looked like a week ago. These are all reported cases. And then on your right-hand side, you see all the reported cases in the United States as of yesterday. And you see an awful lot of more red activity in the Northeast, in the East, in Florida, in some places where social isolation was not taken as seriously as it should have. In Washington, we're doing a little bit better. A week ago, we had 3,678 cases, and as of yesterday, we had 5,984 cases. And I have to say, we're doing much, much better in the state of Washington because people are observing the social distancing much more so than some other states. So we're doing a good job, but overall, we still are rising exponentially. So there's a concern with that, because here in Orange, you see this is what happens if we don't do social isolation or distancing. Then we're going to have a very fast spiking of cases. And you can say, great, everybody gets it, and then hopefully everybody is immune, and then hopefully we can move on. Our healthcare system's not going to be able to absorb that. And then we're going to have a situation that we have in Italy, where in Italy right now, people come in and they don't have the ICU beds, they don't have the ventilators, and people literally come in and decisions have to be made. This patient dies, this patient lives, and you know, those are decisions we don't want to have to make. So if we observe the social distancing, then we're going to do a much better job of spreading out that curve that they're all always talking about. And then overall, it's going to take us longer to get over it, but hopefully we're all going to make it, and we're not going to stretch that healthcare capacity. So this is the reason behind this really intense social distancing, and why the governor said stay home, stay healthy, and really means it. So how long is this going to be going on, and when can we expect that things are going to be getting better? So from that, I just want to show you the data from the Wuhan region, or from China. So you had those cases that started in December, and then they were peaking sometime in early February, and since then they've come down. And in blue, you see the projection, how they see fewer and fewer cases. Now they let things kind of run out of control in the very beginning, but then they had very tight social isolation. So this is the first case that we had in the case in Washington. So we are about a month or so behind. This is where we are today. The University of Washington is expecting a peak on April 7th, or maybe a week after that. So that's going to be when our peak is, and then after that, we still need to get over the hump. So I think we're going to be looking at social isolation for at least another 2 to 3 to 4 months. So it's really important to be patient here. This is, if we love our grandmothers and grandfathers, the ones that are at highest risk for not making it through an infection, I really think let's be patient, let's stay distant, let's be smart, and make it through this together. So in the meantime, I want to let you know what we're doing through this time of social distancing. Obviously, we don't have clinics like we usually do, and what we do to make sure that you're safe and that your Factor supply is safe. So pharmacy is up and running. Everybody is doing well. So the pharmacy hours are unchanged. There are no distribution concerns at this point. If anybody's had any problems, please let me know. But we've talked to all the manufacturers to make sure that the factories are okay, that Factor is being made, that Hemlibra is being made, that whatever you guys need is still being made. And there's no concern right now, even though obviously there's a pandemic and everybody is affected. We're running 2 separate pharmacy teams because I don't want both pharmacy teams to be, or all pharmacy people to be in the pharmacy at the same time, and then God forbid somebody gets infected and they're all out. So we have 2 people, Susan, who's a new pharmacist who's not on the picture here, and Erica, who I think most of you know. They're working from home so that they're not going to be in the pharmacy. And if somebody gets exposed to COVID, it's not everybody. Should we run into problems and have people who need to be quarantined and they can't come in, or they fall sick, we always have the Hemophilia Alliance pharmacy as a backup pharmacy, just to assure that you all get your clotting factor products, whatever it is you're on. Right now, we recommend that you have at least 2 weeks worth of supply at home at all times. So order early so we can make sure that everything gets to you on time. So, question that was brought up is whether COVID-19 is transmitted in factor. Obviously, we'd had some viral contaminations in the past, and that's really scary. But I can assure you that COVID-19 is not going to be found in our factor. Doesn't matter whether the factor is plasma-derived or recombinant. Coronavirus is a respiratory virus. It's affecting the lungs. It is not known to be transmitted by blood. It is not even known to be in blood. And on top of that, all factor products, plasma-derived or recombinant, are all virally inactivated. So meaning even if there would be virus in a plasma-derived factor product, it would be inactivated because it gets solvent treated or filtered or heat treated depending on the product. So there should be a 0 chance of finding COVID-19 in any of your factor products in Hemlibra or any of your products. So that should be safe. Another question that came up is it safe to receive packages from an area where COVID-19 has been reported? And that's certainly Seattle. So you get shipments all the time. Are they safe? Yes. The likelihood of an infected person contaminating commercial goods is low, and the risk of catching the virus that causes COVID-19 from a package that has been moved, traveled, and exposed to different conditions and temperatures is very, very low. So it is not very likely that you get a package and by the time it gets to you that there would be enough COVID virus on the package that it infects you. But I'm going to get back to how long the virus can live on a package in a couple of slides. So how do we conduct our comprehensive visits? We have not suspended them. I felt that was the wrong thing to do. You still need care. So if you can't come to us and we're not supposed to be sitting together, we decided to continue our comprehensive visits at WACBD, and most of them we do remotely. So what you're going to see there is that you're going to be on the computer via Zoom meeting. That's for all the adult patients at that point at WACBD. And we're also going to do that for the Mary Bridge patients, I think Monday after next. We're going to have some visits scheduled. So Katrina is going to call you. She's going to set up a Zoom visit. You're going to call in, and then you're going to go through seeing everybody. We are still in clinic. We are going to come into the room to be with you virtually. And this is how that's going to work. So Katrina or Daphne or Marcy or Bruno are going to start the meeting. And then Shannon is going to talk to you about your medications and what your recent weight is and whether your demographics and your phone number is still the same. Then the nurse is going to come in and is going to talk to you. Then the provider, meaning Dr. Conkle, Dr. Johnson, Jessamine Choi, or myself, are going to talk to you about how you're doing with everything, just like we always have. Then the physical therapist, either Bruno or Mark, are going to talk to you about seeing whether you have any specific concerns that we can address, or that they can give you some exercises for, whatever it may take, or whether there really is a need for you to come in and have an ultrasound examination and whether that's safe for you. And then Kat is closing up the visit to see whether there are any insurance questions. We've heard that there are an increasing amount of insurance people that are losing insurance because they're losing their job, maybe potentially. So definitely she will be involved to talk to you and troubleshoot what needs to happen. So we still do a few inpatient visits in people who are asymptomatic, so meaning they don't have any of the symptoms of fever, cough, or shortness of breath. So if somebody's completely symptom-free and they really don't have the necessary equipment for a televisit at home, then we still see them at the clinic. But there are very few visits at this point that are happening at the clinic. So that's how we do the visits. So if you have any questions, call in. We can do a televisit for an acute visit as well. We can set those up. Just call the front desk. Katrina is still coming to the office every day, so she's there and she'll answer the phones. Daphne can be reached. So we're all still around. Then I just wanted to give you an update as to what has been happening with nursing at WACBD. Happy retirement to two of our nurses that you may know. Heidi Anderson and Cassie Gleckler have both retired, but I wanted to introduce you to new people. Jenny Lamhartzi and Heather Cobden are two new nurses that just recently started with us. Both of them have a lot of nursing experience, so I hope you're gonna learn to love them like we have. So just wanted to let you know, if there are new voices, that's them. They are not taking call at night yet, so I think if you call after hours, you're not going to hear their voices quite yet. So with that, I just wanted to go back a little bit about how you can stop the spread of COVID. It's very important to not sneeze and cough at anybody. If you cough, try to protect other people by covering your cough. And if you touch things, if you've been out to the grocery store, then try not to touch your face or your eye. Those are portal of entries of this virus. Always disinfect touched objects and surfaces, and I'll talk about that in the next slide. And hand washing is really, really important. And that's not just quick, I'm done, but it's with soap and water. This is a virus that hates soap more so than alcohol. So soap and water is the best thing you can do to get rid of this virus and destroy it. So question I said I was going to talk to you about is, how long does this virus live on a surface? So if you are in the grocery store and somebody just sneezed or coughed at a surface, can you touch that? Are you safe? So according to a recent study where they actually checked that out, COVID-19 can live on surfaces several hours to several days. And that very much depends on what surface that is. If it's a plastic surface, that virus will live on it for 72 hours. So you have no idea when you're going, for example, on a bus or something, who was there before, who sneezed on or coughed on that surface maybe the day before. If it wasn't cleaned, it may still have live virus on it, and you could get infected. So just be mindful of that. It will live 48 hours on stainless steel, 24 hours on cardboard, so a lot less, and that affects your packages. There are going to be cardboard, so by the time it gets to you, it probably has been 24 hours since it was handled, at least from here and in Seattle. So it's going to be much, it just doesn't survive that long. If you really want to be safe, you could take it, put it somewhere for 24 hours before you open it. And then copper is much less. The virus can survive in the air for up to 3 hours, but probably not beyond that. So what can you do? You can wipe surfaces frequently with soap and water, or with anything that has alcohol in it, or disinfectants that has at least 70% alcohol in it. That should do the trick. And then wash your hands, wash your hands, wash your hands for 20 seconds. Sing happy birthday twice. Don't forget under the fingernails, between the fingers. And then you don't want to do that and then touch the faucet with which you just opened or opened up the water. So you just want to take a paper towel to close that. Wanted to talk a little bit about masks, because there's a lot of controversy whether we should all be wearing masks or not. So what can masks do? COVID-19 is found in large respiratory droplets, so that's from sneezing and coughing. The World Health Organization does not recommend that the public uses face masks. They recommend that you cover your mouth and nose when you sneeze or cough. The CDC recommends the use of face masks for individuals with respiratory symptoms. So if you are sick, then you should be wearing a mask, or any member of the family should. the Chinese government did something completely different. They said everybody has to wear a mask. So that's why you see these pictures in the news where everybody's wearing masks. So that might be a great idea and maybe protective, as you're going to see, but that's also leading to an unprecedented global shortage of medical face masks. And that means that the people in the hospital, so nurses, doctors, respiratory therapists in hospitals, don't have enough masks. If this continues, these people are going to walk out and they're not going to take care of you and your grandmother and anybody else because there is no protective equipment for people in hospitals. So I think we need to weigh that it's really important that the necessary people have these masks and that we don't necessarily need them at home. So there are two different masks. So you've probably heard about these round masks. They're called N95 masks. They really fit over your entire face, so nothing should come out the side. And then these other ones, these blue ones, are called surgical masks. Let's talk a little bit about what does what. So the first question is, can infected individuals reduce the risk of spread if they have the virus by using a face mask? So if you're sick and you have COVID-19 and you wear a face mask, can that help to lessen the spread? Absolutely, because it's a barrier. If you then cough or sneeze, you're not gonna sneeze and cough on something. You're gonna sneeze and cough on the inside of your mask. So that's clear that if somebody has COVID-19 or symptoms and they go out or they go around anybody else, they should be wearing a mask. What about an uninfected person? Does it reduce your risk to wear a mask? Does it reduce the risk of you becoming infected? So there was a study that was done that looked at those N95 respirators and that clearly showed that if healthcare workers are using them, it's reducing the chance that they're going to get infected. And if they when they compared that to surgical masks, they found that these surgical masks are also protective. And that's really mainly for healthcare workers. That's where they did the studies. There's some other case control studies where they looked at overall population, and it seems like if you're using a mask, and you're out there in the with other people, then you lessen the risk of getting an infection. So therefore, then the question: should everybody wear a mask? Should we do that? Is it helpful? It may be helpful because it makes people also improve their personal hygiene behavior. It may be a direct benefit from becoming infected. It puts more pressure on if we say we all wear masks, then people who are infected are more likely to wear a mask, and people who are asymptomatic who could be spreading it are going to use a mask. But then again, we're going to lessen the supply for people who are in the hospital who really, really need these masks, and I think it's not warranted. So at this point, we're not all wearing masks. We're just trying to keep our distance from everybody, and we're trying to not cough and sneeze on everybody, and keep the surfaces clean, and stay at home and stay healthy, like our governor said. As far as treatments, there is no vaccine yet. I am afraid we're not going to have a vaccine for possibly another year. So that's the only thing that's ultimately going to protect us. Up until then, we're still going to be at risk. There is no approved treatment. I know that President Trump has talked about hydroxychloroquine. It is not approved, nor do we know whether that really is an effective treatment or not. There are all kinds of trials that are being done right now. The trials with hydroxychloroquine, with an anti-IL-6. there is the thought that if you take somebody's plasma who had COVID-19 and who recovered, so who has antibodies, if we give that to sick people, maybe that's going to help those sick people. And that's a trial that we're actually doing at UW and Bloodworks right now. And there are a lot of other clinical trials that are popping up every day, but there is no treatment yet. So staying safe is important. It's a windy road. There are lots of questions, but I think the most important thing we can do is stay home, stay healthy. And with that, I wanted to open it up to any questions you may have and any answers I might give you.
Well, thank you so much. There's a couple of questions that came through on kind of the chat section. So maybe we can go through those and then just open it up to the group.
Sounds good.
Craig asked, does hot temp or cold temp kill COVID-19 virus?
That's a really good question, and we don't really know. So there are no studies that have been done on that yet. I would gather that extreme temperatures might, or extreme heat might. There's no evidence to know from previous coronaviruses that they're going to be harmed by extreme cold, though.
And then the second question that I know of, there might have been more that popped up here, was in regards to the telemed. Is there HIPAA issues? Are they compliant with HIPAA? How does that all work?
So the form of Zoom we have, there are lots of different Zoom platforms, but the one we are using is HIPAA compliant. So it's HIPAA compliant, and you get a link emailed to you when you start the meeting. So it's only you, nobody else has access to that. So it's not like anybody can just log into that meeting.
Awesome. Okay, so if anyone else has questions that they didn't send in, just go ahead and unmute yourself and ask away.
Yes, hi Dr. Kruse. It's
Hey.
Kruse-Jarres. I was wondering, because I heard the announcement about elective surgeries being postponed, and I'm up for a joint replacement, and they consider that an elective surgery right now.
Yep.
So my question is twofold. One, like, when do you think on the horizon that status might change? And then two, how long is too long to wait for a joint replacement?
So let's answer the last question first. How long is too long to wait? At this point, the joint is damaged. So waiting another 6 months is not going to do anything to the joint. I mean, I know that you would like to have it replaced, but I don't think it's going to have an impact on you. I think right now it's really, really important to not have any elective surgeries, because we need these hospital beds for people who are going to be acutely ill with coronavirus. And you probably don't want to be in a hospital where they have lots of cases with coronavirus, because there's a higher chance of maybe you getting infected. So I would definitely postpone any surgery like that until after we really don't see any cases anymore. How long that's going to take, I don't know. My guess is that nothing is going to be back to normal until maybe late the summer, if then. And even then, we're going to have to see whether there might be a second wave as we go into fall. So it's really hard to predict. So I'm just asking you to be patient right now. I think it's safer not to do the surgery at this point.
Okay, cool. I was just bringing it up because the last hospitalization I had towards the beginning of February, before the outbreak, the orthopedic surgeon that was on the floor had wanted to do it there before they even discharged me from the hospital, as it had gotten to the point where the bone is shaving off. So I'm losing bone mass at a pretty fast rate. That's why I was wondering if that changes the circumstance of.
It doesn't. So, unfortunately, you're talking about a joint that has been destroyed.
Mm-hmm.
and whether it gets a little more chipped off at that point, it's still going to be the same outcome, and you're going to
Oh,
need joint replacement. And whether you get it now or whether you get it in 6 months or a year, for the bone, it's not going to make a difference.
okay. There was also another one. Speaking of hospitalizations, so I came close the other day so another problem stemming from the joint replacement was because it's so damaged and it's bone on bone, even the Hemlibra isn't stopping all of the bleeding. And I had gotten a bleed just like a week ago. That was the point where I had to call in, and the recommendation was to go into the ED. I made a personal call to just wait another night to see if it would stop progressing. But it had come really close, and then obviously I was trying to avoid the hospital because of everything that's going on. And I was just wondering, what are your thoughts on on the severity of the bleed? Like, how many Novo doses, before we have to come in, or is it something like, what other factors determine that, or is it just that I need an evaluation from a hematologist?
Well, so usually if you're on Hemlibra and you've taken your 3 doses of Nova 7 and you still have, it's still not getting better, then I think at that point it would be appropriate to either go to an emergency room, but you just need to know what emergency room you have around you, and you don't want to be sitting in a waiting room with a lot of people who are coughing and sneezing and might have COVID-19. So I would avoid that at that point.
Okay.
You can definitely call. I mean, first thing would be to call the hematologist,
Right.
the treatment center, and say, this is my situation, what should I do? And then they can walk you through it and say, well, this ER is safe, go ahead and go to that, or take another dose, or do we have the capacity for you to come in and do an ultrasound to see whether it's really bleeding?
Okay, cool. Thank you.
Sure.
Let's take one from the list here.
Yep.
Great question from Capri. She wants to know how the conditions are at Children's Hospital, and if we have a kiddo that has symptoms, how does hemophilia change or affect this? And add anything else to Caprice if you had more to your question.
Yeah, so the situation at Seattle Children's, I don't know, I think, is Amanda, no, I don't think Amanda's on this call.
But we do have her slated to come and chat, like specifically what she wants to remind the kiddos, parents and stuff, and children, so we could get that expedited too.
Right, and I don't really know what the situation is at Seattle Children's as far as ER or admissions. I know that they're not doing comprehensive clinics right now. We're trying to see how we can make up for that. I'm sorry, and the second part of the question was?
If your kiddo has symptoms, how does hemophilia change or affect this?
It shouldn't at all. I mean, you should, if you have symptoms, you still have to quarantine. The COVID-19 is not known to increase bleeding or make bleeding symptoms worse in children. So you would do what you usually do. And the recommendation right now is that you call your doctor, your primary care, your pediatrician, and if they would then refer your kid for COVID-19 testing, and they're usually done outside of the hospital in these parking lots where people drive by and they just get tested. And then you go home and you get the test result to see whether your kid has COVID-19 or not. And the recommendation is not to go to inside the emergency room. Does that answer your question?
I think she looks like she's still knitting, so I think we're good. Okay. Then the next one here is it possible to be infected and not show any symptoms?
Yes, absolutely. Yes, and we have no idea how many people are asymptomatic carriers, if you will, because there's just no testing done. unfortunately, because there are not enough test kits to just say, hey, we're going to test everybody and then see how many silent people there are. But we definitely know that there are people who are asymptomatic, but who test positive for COVID-19.
Okay. The next one, these are really great questions. Just keep bringing them in, guys. It says, if somebody with hemophilia with an inhibitor had to get intubated due to complications of coronavirus, how would that work?
That would work like any other surgery. I mean, we would definitely need to and want to be involved. So we just, depending on what the inhibitor status is at that time, and that's why I always check it. So if the inhibitor is dormant at that point, we could give some factor VIII. If the inhibitor is not dormant, then we would give a bypassing agent like we usually would. But I definitely think that anybody who is intubated or gets intubated, or anybody who is in an ICU setting, needs to be on some kind of prophylaxis, because you never know when a procedure needs to be done.
So it'd be really great, since you have to be on your own, make sure everyone has their medical ID bracelet on.
Yeah, always. Not
right,
just
like what I'm hearing is that you go on your own, right? There's not, your advocate, right?
Yeah.
Like,
Yeah.
so,
But definitely, I mean, if you have any symptoms and you're going in, or that you're going to be admitted, please let us know so we can make sure that you're safe while you're in the hospital, and we can talk to your primary team there and make sure that you get your hemostatic treatment.
okay. And maybe we can make like a little cheat sheet or something people could take with them, or their family member. It's always so hard when you're in crisis to remember what to do. Okay, so
that's why we're here.
Yeah,
So,
yeah.
if you're in that kind of crisis and you're worried about the COVID-19 and need to be admitted to the hospital, if we're involved, we can make sure that the bleeding plan is being observed. So you don't have to worry about that.
Okay. So they are saying that, you like how blind I am? I'm like, oh, this one. They are saying that people with certain conditions should be extra cautious because contracting the virus could be more dire or fatal for them. Would von Willebrand's disease be one of those conditions? I know that my healing ability in general sucks compared to others without VWD.
So that is very true. Von Willebrand, or people with von Willebrand disease, have slower healing. However, that is not likely to affect any coronavirus outcome. So the things that have been associated with worse outcome with coronavirus are people who are older than 65, and definitely older than 80. Those have worse outcome, and people with comorbidities. So people who have COPD, lung disease, diabetes for some reason, but not other bleeding disorders.
Quick question. What about if you have a history of pneumonia?
That's a really good question. That's really not known. So if you had pneumonia, but there's no scar tissue from back then, and you have full lung function, then it shouldn't affect you. If you had pneumonia and there is scarring and decreased lung function from previously, then it could affect you adversely.
Okay, thank you.
So here's the next question. Any thoughts on the use of NSAIDs and COVID? I know our bleeders shouldn't be using as much as possible anyway.
Right. So at some point there was this thought that, it was in the press that you shouldn't use ibuprofen for COVID, which is total baloney. There's no data on that. So then everybody said, no, it needs to be Tylenol. Now, people who have bleeding or easy bleeding shouldn't be taking ibuprofen or NSAIDs anyway, and should be taking Tylenol. So if you have a fever, so let's say you have symptoms, and whether you've been diagnosed with COVID or not, it always helps to take Tylenol for a fever, just to bring the temperature down. There's no need to really be writing out a fever and not do anything about it. So then I would just do the Tylenol anyway, because the ibuprofen is going to add to the bleeding risk.
Great. Well, those are all the questions everyone sent in. What about anybody have a question that they just want to say?
All of my two out. You're supposed to ask
Any general comments that anyone has?
How do you think the coronavirus will affect the pharmaceutical economic?
I'm sorry, you broke up. What was that?
How do you think COVID-19 will affect the pharmaceutical economy?
The pharmaceutical economy, for clotting factors or in general?
For clotting factors.
I don't think it's going to affect it at all, because people don't bleed more or less. So I think that's going to be pretty stable. Everybody's going to stay on, if you were on prophylaxis before, you're going to stay on prophylaxis. I mean, if we see that we're losing a lot of our workforce, could that potentially at some point influence how much clotting factor can be manufactured? That could be a potential problem, but so far we don't really think, and none of the manufacturers seem to think that that's a problem.
Okay.
Okay, there's another one that was texted in here. A couple of months ago, a lot of people had a really bad flu with high fever and lingering cough. Now there is speculation that may have been the first wave of COVID-19. Do you know if there is any truth to this? Has there been any challenges with people losing their jobs and insurance coverage yet?
So two very different questions. So the first question, yes, that was a flu wave, and I was part of that, and several people I know were part of that, and that was in January and February, and it's really difficult to tell whether at that point that was COVID-19 or not. We didn't test, we didn't even have the test, it was not on our radar. To really know how much COVID-19 was actually in our community in January and February, we don't know. So the way that can eventually be answered is if we do antibody testing. So what happens when you have COVID-19, the first test you do is you actually test for the virus itself. That's the RNA. And that's the testing they do right now at UW or wherever you go. That tells you whether you have active virus. And then the next thing that happens, that most people are eventually going to have antibodies against COVID-19, and that's an antibody test. Those antibody tests probably turn positive 28 days after the infection. So 28 days after your symptoms, potentially you could do that antibody test, and that would tell you whether at some point you had COVID-19 or not. That is not a readily available test yet, but my expectation is that that's going to be something that is going to become very available in the next month or two, because we need to know, as we're hopefully emerging from this social distancing and isolation, as people return to the workforce, we need to make sure that people are immune, and that we know that they're not going to infect anybody and they cannot get infected again. So in Germany, they're actually talking about giving green certificates to people who have antibodies to say, have been infected, don't have the disease anymore, I cannot hurt anybody and I cannot get infected. That was one question. And the other question was people losing their jobs and therefore their insurance. I'm starting to hear that being a problem. And that's why I said, please let us know if that's an issue. Let us know early so we can make sure that we help you through that. I know Stephanie and the BDFW are very involved in that too, if you need any help. If we need to apply for compassionate factor use for a while, that takes a little while, but we can get compassionate factor if you lose your insurance.
And we're here to help people sign up for Medicaid and look at their options too. Okay, so a couple more questions have come in. If hospitals get overwhelmed with COVID patients and have to start deciding who gets treatment and who doesn't, will hemophilia lessen your chance of getting treated if you are otherwise healthy?
So that was a huge concern, and I know that I've talked to UW about that absolutely should not be a contraindication. People with hemophilia and bleeding disorders have a normal life expectancy. They should not be on a blacklist or not get treatment. So far, at least talking to UW, I know that people are not on a list like that. So it shouldn't lessen your chances.
Okay.
Oh, sorry. I just had a quick one. So I did hear that if you're on high blood pressure medication, that especially the ACE inhibitor, the ACE inhibiting kind, puts you at a higher risk for the progression of the disease. Like how does that, like how much does that escalate it? Do you have to be like extra care, or do you want to go in sooner when experiencing those symptoms, or?
So, I mean, this is a thought, but it's not proven by any data.
Okay.
So it's something that people are looking at to see whether there's truth to that, but there is no data at this point to support that.
Okay, so it says, when do you think the antibody test will be available? Have you seen the efficacy of those tests yet?
So the antibody test is the antibody test is already available at some institutions. In mostly on a research basis. It's been submitted to the FDA for approval by several companies, actually, an emergency approval. So hopefully we're going to see this relatively soon. When are we going to see that widespread so everybody can get tested? It's probably going to be at least a month or two, if not longer.
Okay.
And the efficacy. So for one, I want to talk about the efficacy of the COVID-19, the RNA test, so the PCR. So that's whether you actually have the virus or not. That has not a very good sensitivity, meaning it does not necessarily, if it tests negative, it doesn't mean that you really don't have COVID-19. So it's not 100%. And that is because if they don't get a virus on the nasal swab and they do the test, then they don't check that, then they don't get the RNA, and then it's going to turn negative. The antibody test is likely to be much, much more sensitive, so a much more reliable test.
Okay.
Question. First of all, hello and thank you, doctor. This is Oli. Hello.
Hey, how are you?
Good, how about you? Get in so she can see. Yeah.
Hi, Ben. How are you?
Good, how about you?
I like your screen in the back there.
Thank you. And then we wanted to, before the question, say hello to Bruno, please, for us.
I will do that.
And then the next question, the actual question is, I read something about some people being sick again with COVID-19. Is that baloney or is it true? And if that's true, then what's the deal with these green stickers? What do they mean?
So this is a really excellent question, and it's one that I am reading a lot about. The cases where that was reported are all from Chinese, from those people or some of the people in China. It's not a very common phenomenon, but there are a couple of cases that have been described. And the question is, was there potentially faulty testing? So that goes back to that RNA test. To check for the virus. So could it be that that these were patients that were quarantined in one of the hospitals, then they were tested again with the swab, with the nasal swab. If they did not do the nasal swab right, that may have come back as a negative test, and then they were tested again later, and then they were positive. Were they really negative? Or did they just miss the virus when they did the testing right before they let them go? So that would not be a recurrence. Immunologically, it makes no sense that somebody becomes immune and then right after that gets infected again.
Okay.
So
none of these cases are from the U.S. then?
None of the cases are from the U.S. These are all from China.
Anyway, so that works.
Yeah.
Thank you.
But it's something that we are all watching super closely to make sure. I mean, like I said, it doesn't make sense. It's not something that we have seen with any other coronaviruses. So it would be highly unusual, but that doesn't mean that it can't happen, and we're going to check that very carefully. Very good question, though.
Okay. So we have one. My daughter had a high fever and was tested for influenza B. Would it be likely for someone to have the flu and COVID at the same time?
It's definitely possible. Definitely possible. And unless it was checked, we don't know. I mean, eventually, like I said, the antibody testing is going to tell you. But yeah, and I think there's probably a lot of co-infection because flu and COVID-19 were circulating in the same community at the same time.
Okay. So that was the last question I had right now. Anybody else have any questions? Alrighty. Are we just all ready just to say thanks to Rebecca and see each other the next time we all kind of get together here? And feel free. Oh, wait. If it was. I mean, I'm reading like, don't you love my blindness? Oh my gosh, I'm so embarrassed. If it was before the outbreak, so I was just curious. There's no other symptoms. It was just a little curiosity. Thanks so much for the information. Sorry, just want to make sure I wasn't missing anyone's question here. So just keep letting us know what you need and info that you're looking for, and our thoughts are with everyone. And lots of people are sending in messages of thank you, Rebecca, as always, for your time. You're always so generous with it.
Well, and please, let us know if there are any problems with receiving care or getting a hold of us or getting your medication. I would really want to know about that. If you don't want to talk to me personally, let Stephanie know. She'll definitely let me know.
Who would not want to talk to you personally? That's my question.
Some people might not, but no, but I mean, definitely, I really want to make sure that this is as smooth as it can be. And if there is any trouble in receiving care, I always want to know about that.
And then I have a quick question. Since I didn't know how close to time the discussions between Rebecca and Amanda, would you guys like to hear about what's going on at Children's sooner than later, like next week, or do you want like 2 weeks?
Whatever works for them.
Yeah, whenever she's
but
available.
If it's recorded, then you can just go ahead and share the link with everybody, and that's it. As long as it's recorded.
Soon, I'm hearing some soons. Okay, I'm trying to be really conscientious. Like if we oversaturate you, let us know. But otherwise, we'll get that up and running. I think they're kind of different infos, so I'll solidify a date with her.
Anything you guys send is always welcome. So send.
Oh, thank you.
You don't get it. We're all bored right now.
I know. I just
I'm not
super bored, Michael.
Some of us are working all the time, so we're not bored. But
yes, we can send all sorts of stuff. But yeah, okay.
Yeah,
good.
I say as their time allows, that would be great. I think because the information changes so much day to day.
Yeah.
This is great. That if you could get her in the next week, that would be awesome.
Okay. Yeah, I know she's set. I just wanted to pace everyone. I mean, so. But yes. Alrighty. Well, thank you.
No, thank you.
All of you.
thank you.
Okay.
You as well.
Thank you.
Alrighty. Lots of love, everyone. Stay clean and healthy.
Bye.
Thanks. Bye.
Bye, everyone.